My name is Jaime Sanders, and I have the blog The Migraine Diva, and I am a participant of CHAMP. Chronic pain has been synonymous with living for me ever since I was a young child. At 8 years old, I was diagnosed with migraine. From childhood, I have had the burden of having an invisible illness and growing through many stages of invalidation, dismissal, and unacceptance of having one. As a kid, I was exposed to how much migraine can take away from your life, and that was painful. I was not the same as other children, and no matter how much I looked normal on the outside, my body prevented me from showing up in the world in the way that I wanted to. As a woman who grew to have a wonderful marriage and 3 beautiful children, pain was still a major and persistent part of my life. By the time I was 30, I had chronic migraine, daily chronic headache, new daily persistent headache, fibromyalgia, and a 6, 7, and a 10-year-old to take care of. Finding and receiving adequate and equitable care over the last 15 years has been more challenging than it should be. I have had to appeal many decisions not to cover treatments in order to ensure that I am getting the most efficient pain management therapies. Access to see a headache specialist was impossible, as my insurer would constantly deny referrals to any outside of their network, limiting my care to neurologists who were not specialists in headache medicine. They tried what they could, but often I exhausted the most common treatments, which either failed me or lost their efficacy over a few months. Thankfully, a headache specialist was hired in 2016 by my insurance provider. However, he is located 2 hours from me in Baltimore, Maryland. Every 3 months, I drive 4 hours round trip for injections. Is it what I prefer? No, it is not. But this is my best option to receive migraine-specific treatments. As a woman of color, I have experienced too many times clinicians asking me if I'm doing enough to manage my pain. There is often this implication that I am doing nothing to get better and just drug seeking. I am sure that this could be an implicit bias stemming from the stereotype that Black people are lazy or substance abusers or waiting for a handout. Since I travel with a binder that validates the existence and seriousness of my disease, an urgent care doctor who I saw several times in the past thought it was okay to refer to me as the binder. When I self-advocate, I am perceived as angry or combative. A Black woman who is deeply knowledgeable about her disease and what treatments are effective for her is not always well received. A neurologist I was seeing for several years told me during an appointment that I was the reason why I was in so much pain, claiming that I relied too heavily on medication and have not made enough lifestyle changes. After going down a laundry list of complementary, alternative, holistic, and naturopathic treatments I utilize outside of the necessary medical procedures and therapies that are a part of my overall protocol, I fired him. I was no longer able to work due to my many pain conditions. To help supplement my family's income, I applied for Social Security disability in 2005. This decision was not an easy one to make, as I want to be able to provide and be someone who can help my family financially. Not being able to have a career was a hard pill to swallow and a hard reality to become comfortable with. However, it took 9 years to get a full award approved for Social Security disability. In 2018, Social Security determined my health was improved enough to go back to work, although I have chronic intractable migraine, which means I am in pain every day. It took over a year to fight and reverse that decision. Why did this occur? The Blue Book contains no listing for any headache disorders, nor are they updated on a scheduled timeline. The patient's voice is not a part of the disability evaluation process. The Social Security Administration discriminates against people with invisible illnesses by only using signs and not symptoms to determine eligibility. During my first determination hearing, the judge asked me why I had more children if I knew I had migraine. He approved me for a partial award, sending me on another long appeals process. The second judge I had spoken to me as if I weren't in the room or even a human being, both of them showing racial and gender bias toward me. After my approval, I had to undergo several disability reviews, sometimes twice in 1 year, to prove that I am still disabled. Are you aware that the Alliance for Headache Disorders Advocacy is working on a proposed solution to these issues through its Patient-Centered Disability Evaluation Act? The PCDE looks to address these inequities through 3 main avenues, including the patient's voice in the determination of the disability evaluation process, having the Blue Book update their listings every 5 years, and addressing the discriminating policy of only allowing signs and not symptoms to be used to support determination, a step 2 of the 5-step sequential evaluation process. Since COVID, I have been unable to access infusion treatments or acute emergency care for severe flares of migraine that no longer respond to treatment at home. I have had to postpone necessary in-office treatments to help manage my daily pain by months, causing severe spikes in pain. What has remained constant, however, is the availability of telehealth services. This has been an option for me for many years prior to the pandemic, and it has allowed me to keep appointments despite high pain days, provided flexibility in scheduling when my children were still in school, and allowed me to see my therapist and pain psychologists who were not close to me more regularly. Migraine patients have been early adopters of telehealth, as it is an important part of chronic disease management. Expanding virtual care beyond the pandemic is crucial for people living with chronic illness, especially women and people of color, who are often burdened with childcare, are essential workers, and may not have access to equitable care. Legislation, such as the House Telehealth Caucus Bill, which seeks to push forward with wider access to and use of telehealth beyond the public health emergency, can help ensure that they can safely access care when and where they need it. In conclusion, the life of a woman with chronic illness is one that comes with many obstacles. Unfortunately, there is no roadmap given on how to traverse the many roadblocks thrown up against us when navigating the healthcare system. You are forced to learn it through overcoming access barriers and self-advocating through your pain. Being a woman, my pain is dismissed as distress. Being a Black person, my pain is not perceived as being real. The challenge is, who is going to show up in the exam room and see and validate my disease, as opposed to only seeing my gender and race?